Hello, my name is Thom Luxon. I'm an advanced clinical practitioner.
And my name's Logan and I'm a physiotherapist.
This talk was initially advertised as post-stroke spasticity. However, our main focus today during this presentation will be to talk to you about the assessment and management of pain and our experiences of the multimodal management between the multidisciplinary team. We will talk about the recognition of pain, measurement of pain, and then move on to discuss a proposed quality improvement project focusing on pain and spasticity management. As often, pain can be a trigger of spasticity, and one cannot focus on either in isolation. Pain is an experience had by all. The definition of this varies from textbook to textbook. However, these definitions can be used to understand what is ultimately a subjective experience. Around half of stroke patients will experience pain in some form. It is careful evaluation of this which allows for appropriate MDT approaches to its management. As you can see, pain is a distressing experience, but importantly has a major impact upon the psychological well-being of patients and can therefore impact greatly on their recovery. Firstly, we need to know how to recognise pain and make sure it is something that we ask about with all of our patients. We can notice pain in the simplest of our interactions by looking at changes in facial expression, noticing if a patient is reluctant to be handled or is guarding of their limb. And on testing, we may see exaggerated reactions to stimuli. We need to listen to the language used by our patients. It's always good to have a knowledge of the stroke vascular territory the patient's insult is in. This can give us an insight into the likelihood of pain being a post-stroke complication. Central post-stroke pain is neuropathic pain characterised by pain or sensory abnormality in body parts corresponding to the area of a lesion or stroke in this instance. Prevalence of central post-stroke pain has been reported between 1 to 20% and even up to 35% in some meta-analyses. It is poorly reported and often a misunderstood concept. And previously, thalamic lesions were thought to be the initial cause. However, extrathalamic lesions are also now recognised. Please take a moment just to think about which areas of the brain affected by stroke most commonly lead to central post-stroke pain. On this slide, you can see a picture which demonstrates the most commonly reported locations of stroke which have been identified as leading to central post-stroke pain. As said previously, the thalamus, cortical strokes within the somatosensory strip and the parietal region of the brain, small vessel strokes, lateral midbrain strokes and pontine strokes, commonly reported in lateral medullary syndrome. Interestingly, we find central post-stroke pain is more commonly reported in right hemispheric strokes than in left. Thalamic strokes account for around 1/3 of central post-stroke pain that have been reported. It is paroxysmal in nature and severe. Allodynia and hyperalgesia have also been reported. Lateral medullary syndrome is the most common brainstem syndrome in which we see central post-stroke pain. Approaches to the assessment of pain can vary, however the most important principle is that of initial history gathering. We recommend the use of the Socrates tool to allow you to establish a good baseline history. Using this tool, we ask you to focus on the site of pain, when the pain began. Ask the patient to use descriptive words to identify the character of the pain. Is it burning, stinging? Does the pain radiate to elsewhere in the body? Are there any other associated factors, any other symptoms that we need to be aware of? Does pain come on or stop at any specific time in the day? Is it exacerbated or aggravated by any activities? And we can ask the patients to identify the severity of their pain using a simple score out of 10. How is this helpful to us as an MDT? Firstly, a good history allows us to identify the nature of pain. Is it central post-stroke pain, neuropathic in nature? Or is it musculoskeletal pain, nociceptive? Or are there elements of both present? How can we use all of our skills to develop a management plan? Can we use positioning in isolation, or do we need to consider the introduction of analgesics? We must at this time remember the impact of polypharmacy upon our patient group. We can use validated pain assessment tools to assess the impact of our interventions, such as the SLANs, visual analog scales, numerical rating scales, and even simpler body charts. Here is a representation of the SLANs pain score tool. As you can see, initially there's a body chart and a numerical rating scale to identify the site and severity of pain. The questions here are completed by the patient, or we can just do a LANS and do it with the patient ourselves. If you look at the questions individually, the first asks around the presentation of pins and needles or altered sensation, changes in colour to the skin, hypersensitivity. Asking these questions and with simple yes or no answers, we can use the scores to hopefully identify whether we feel the pain is neuropathic or nociceptive in nature. Here we see some examples of visual analog scales and numerical rating scales. These can be used for patients who may have communication difficulties, using a simple drawing on a line to identify how severe their pain is, or even using pictorial representations of pain to help patients communicate their experience. We can also use simple body charts to be really specific to identify the site of a patient's pain. Commonly, we are asked to intervene with analgesics. Our aim here is to reduce the experience of the patient's pain. We always try to do this with the lowest doses of medications possible, and using our assessment tools and history, we should be able to make appropriate choices of analgesia. We can use a standard approach of upward and downward titration of simple analgesic medications. However, if we identify neuropathic pain, we may wish to consider alternative approaches and formulations. In our experience, neuropathic painkillers are increasingly used. The most commonly used on the stroke rehabilitation unit were pregabalin and gabapentin. These are anti-epileptic drugs which have an impact upon neuropathic pain. The mechanisms of their action are poorly understood. Although the pathophysiology is available, it is far too complex to address in this presentation alone. So how do we decide which analgesics to start? In the case of neuropathic pain, our local trust policy would always suggest first line would be a tricyclic, such as amitriptyline. There is good evidence for the use of these in the management of neuropathic pain. However, due to the comorbidities of our patients and frailty we experience, we want to avoid the anticholinergic side effects that these can produce. We've noticed that gabapentin following amitriptyline is the first line in the policy to be used. However, we noticed that pregabalin is increasingly used as there is a perceived benefit in the management of spasticity. Tricyclics are a much cheaper drug choice. Gabapentin is cheaper than pregabalin, and we know that we would like to use the lowest dose to manage pain.
So our project came about because there was a perceived lack of structured MDT approach to the management of pain and the management of spasticity. Pregabalin was often being just prescribed without a real concrete plan for the upward or downward titration, and there wasn't really a joined up approach for pharmacological and non-pharmacological management. So we completed a retrospective audit of 30 patients admitted to stroke rehabilitation units and looked through their notes for mention of spasticity or pain, the prescription of neuropathic analgesia, whether there'd been a pain assessment tool used, and whether there was a documented MDT discussion. And you can see our results here. So 11 out of the 30 patients had pain or spasticity documented within their notes. Only 4 had a documented MDT discussion around it. And I think we're very aware that discussions happen kind of ad hoc, but they weren't being properly documented. None of them had a pain assessment tool used or had a spasticity outcome measure used, and 9 of them had been commenced on neuropathic pain management by the medical team, all of whom had been started on pregabalin. So in summary, there wasn't a standardised approach to discussing or managing pain or spasticity in the MDT format. We were prescribing pain relief with no discussion and no kind of joined up approach around what we were doing from a therapy perspective and from a nursing perspective in terms of the non-pharmacological interventions. So we couldn't really measure the effectiveness of what we were doing. So we came up with a plan of completing weekly MDT pain and spasticity meetings alongside our MDT meeting to really add the depth of what we're doing and why we're doing it. We're going to use the SLANs to look as an outcome measure to look at kind of both, do we know what kind of pain we're treating, are we treating it correctly, and are we being effective in our treatment? We plan to complete in-service education within the service to look at both the recognition and the assessment of pain across the MDT, and then with a plan to re-audit in 3 months' time to allow for embedding of those plans, and then to kind of repeat the process to look at our future work on this topic. So I'm going to talk a little bit now about the guidelines in terms of pain and kind of the management of that, and a lot of it talks about shoulder pain, but I think what's relevant to shoulder pain is probably relevant across the board really. So the NICE guidelines tell us to provide information for people with a stroke and for their families and carers on how to prevent pain or trauma to their shoulder, and it talks about using appropriate positioning and other treatments according to each person's needs to manage their shoulder pain. The RCP guidelines tell us that patients who have risk of shoulder pain should be reduced through careful positioning of the arm, de-weighting of a limb or supporting the weight of a limb, ensuring that families and carers handle the affected arm correctly, and avoiding mechanical stresses and excessive ranges of movement. People with arm weakness after stroke should be regularly asked about their shoulder pain, and people who do develop shoulder pain should have the severity monitored and recorded regularly, use a validated pain assessment tool, and have preventative measures put in place and offered simple analgesia. So I think often when we think about pain after a stroke, shoulder pain and subluxation is something that we think about. So with a prevalence of around 17 to 25% at 6 months, but with approximately half of those patients reporting pain in the first 2 weeks after their stroke, which is quite significant really in terms of kind of the acute management and the early management of shoulders and shoulder pain. So it's often associated with higher NIHSS scores and reduced arm function, and pain is often described to be moderate or severe. As we know, inadequate analgesia can impact on rehab. It can also impact on quality of life and does correlate with depression and low mood. So within a study by Passy et al, they found a significant correlation between shoulder pain and subluxation, with 41% of the patients that they included in their study reporting pain and subluxation. Lindgren et al in 2006 found that shoulder pain and subluxation can occur together, but can also occur in isolation, and there's not always a causal link. Even if they occur together, there can be 2 separate causes. So the next slide talks about the non-pharmacological management of pain. So we all want to know what we should be doing and what the evidence tells us that we should be doing. So what we know is prevention is best, and it's everyone's responsibility to look at what they can do to support somebody in terms of both preventing pain and then the management of the pain if it does manifest. So the evidence isn't sparkling for any of the interventions that we do, so it can be difficult to know what we should be doing to support our patients and their families or carers. As in the previous slide, the guidelines tell us that we should teach patients, families and carers to look after a limb. and positioning and supporting the limb is a big part of that. So we use clinical photography, we use diagrams and positioning pictures to provide a consistent approach for everybody supporting that patient across a 24-hour picture. Splinting is an option that we use, so both upper limb and lower limb splinting. We wouldn't do it routinely, but where it's required to maintain range of movement, it's a good option. A recent review of splinting looked at static, dynamic and robotic splinting, and while there was limited comment specifically on pain, where pain was driven by stiffness or spasticity, they were found that they would be useful. There's a variety of different taping techniques that we can use, and there's quite limited evidence for the taping of shoulders and other limbs. So Ravichandran in 2019 found sufficient evidence for taping to reduce pain and subluxation in stroke. Huang in 2017 found that when they taped shoulders for 3 weeks, they found reduced pain. However, it's quite difficult to generalise those results because the papers that they used a variety of different techniques, and so it's quite hard to know what the best thing is to use. Anecdotally, there's evidence around improved alignment and reducing impingement. So again, on a patient-specific basis, it's worth looking at to see if that can change their pain. And I find it's very much a trial and error approach, and it's using your clinical reasoning of what you feel like you need to change or what you think you need to change within that limb to try and reduce the pain and kind of what the causes of the pain are. So arm supports are an option, particularly if someone's on their feet but has a kind of dense low tone upper limb or has pain in their upper limb. But again, there's not a huge amount of evidence for either using a sling or a support or the type of support that we should be using. So the options we could use are kind of Neurolux braces, subluxation cuffs, polyslings or supports on the wheelchair, so like an arm trough. Cochrane review in 2005 showed insufficient evidence to conclude if a sling or a wheelchair attachment was beneficial in the reduction of pain, and also whether they prevented subluxation or increased function. Chuang et al. In 2017 found a positive impact of electrical stimulation to the long head of biceps, supraspinatus and posterior deltoid. They found a reduction in pain on a visual analog scale when they used it in conjunction with bilateral arm training. And TENS is also an option that some patients find beneficial in the treatment of their pain. Then options such as acupuncture, which is used less widely in the NHS in the neurological population, but there's a variety of different techniques, some really weird and wonderful ones using bee venom, electroacupuncture, that did have some positive influence on people's pain after a stroke. And then passive and active range of movement, so low amplitude movements where pain is an issue can aggravate the joints if completed aggressively, and particularly kind of you would want to avoid excessive overhead exercise, but range of movement is often beneficial in terms of kind of joint stiffness. So then we probably want to treat their postural instability if they are posturally unstable. So if we treat this, then potentially we're going to reduce the amount of assistance they need to transfer, or potentially reduce their risk of falls, and therefore both hopefully, if they're not falling as much, then potentially we reduce the pain of any injury post-fall, but would also reduce the quick stabilising movements that they'd need if they are more unstable, and create more efficiency within their movement. And lastly, giving people regular opportunity to move. So often people manage their pain, particularly if they had pain pre-stroke, by moving and then suddenly being put in a hospital bed where you aren't able to move, or even being at home and being more static than you would normally be. So giving people regular opportunity to change position and move between a bed and a chair, or move around a ward environment or a home, again allows them exposure to different postural sets and a change in position, really. So a systematic review completed by Dyer in 2020 concluded that they're unable to provide evidence-based guidance on treatments due to the quality and the size of the studies and the variable outcomes within them. I think a lot of the techniques were quite different. I talked about the taping techniques, that they were different, but there wasn't a lot of kind of applicability across the board, really. And I think the bottom line of it is that it's a complex etiology with often multiple factors that feed into that. So we need to have a wide toolkit to be able to provide an evidence and individualised approach to the management of somebody's pain as part of their treatment.
So what's next? We've implemented the current test of change that we've talked about, which was our weekly stroke pain and tone meeting. We've already delivered some educational presentations to our community stroke colleagues. Our aim is to increase our MDT approach to the assessment and management of pain by joint working and joint assessment of patients. Our aim is to identify those patients who have long-term risks of post-stroke pain so we can ensure they have adequate referrals to ongoing chronic pain services. And for example, in our local stroke service, patients who will be followed up by a non-medical consultant, we would like to ensure that their pain is addressed and continuously managed as they move through their rehabilitation and life after stroke. In summary, we've identified that pain post-stroke has a high prevalence. We know that the pathology of this is unclear. It is multifactorial in nature, and there are different management methodologies we can use as an MDT to try and improve the patient's experience. Good assessment and history taking is key, and we need to address the wide toolkit that Holly spoke about to try and manage a patient's pain. The MDT, I will say again, is key to the management of pain. It allows for interaction of medicinal and non-medicinal interventions and the assessment of their outcomes. We also think that there are areas for future development, specifically looking at the non-pharmacological management of pain post-stroke.